Sorry, I had to record before saying good morning. Hi, good morning. Thank you for being here this Sunday morning and joining us. Thank you to those online from all over the world. So, good afternoon and good evening and good morning to some of you. Thank you for joining us this morning. We're starting Math Matters Civil Society Drives Health Through Oral Health. So, this is an official UN side event to the fourth UN high level meeting on NCDs. And all I'm doing right now is introducing one of my favorite mentors, Dr. Fernando Hugo, for the welcome remarks. So, Dr. Fernando Hugo is chair of the Department of Epidemiology and Health Promotion at New York University College of Dentistry. He's an associate professor with extensive expertise in oral epidemiology, global oral health, aging research, and public health. Dr. Hugo has published more than 200 articles in peer-reviewed journals and leads research focused on oral health disparities, social determinants of health, and preventive strategies to improve population oral health outcomes worldwide. Under his leadership, the department advances interdisciplinary research and training initiatives integrating epidemiology with public health policy and clinical applications. He's recognized internationally for his contributions to oral health equity and global health collaborations. The floor is yours, Dr. Hugo. Thank you.
Thank you, Kiran, for the kind introduction. It's a pleasure to be here with everyone this morning. In I'm here representing our dean, Charles Bertolami. Dr. Bertolami asked me to extend his welcome to everyone who's attending today. He was unfortunately not able to be here because of a prior family event that he has to attend. So I'm here representing him, and really, I think it says a lot that we have a lot of people in a Sunday morning, and it says a lot about your commitment to oral health and times that we're living with so many different things affecting our daily lives and everything that we're living right now. By no means these are simple times, I'd say, times of really a lot of challenges that we have to face. And I think that global oral health is certainly one important challenge that we really need to look at. And I believe that events like this one are really important to bring everyone together and to promote discussion that is central to, again, bringing oral health to the broader, wider global public health agenda. So really, thank you everyone for being here. And thank you, Kieran. Thank you, Deborah, for taking the lead and organizing the event. Your contribution and your work, your leadership is certainly central for us to be here today. And thank you for organizing a great lineup of presenters who will be sharing their knowledge, their expertise, their work with us this morning. So really, again, thank you very much. Thank you both for putting up this for our Sunday morning. I'll start by introducing my friend, Dr. Deborah Weisfuss. Deborah has received an MS in biomedical research from the State University of New York at Downstate Medical Center, and her DMD from UPenn School of Dental Medicine. Her general practice and chief residency were at Northwell Medical Center here on Long Island. Sorry. She's currently the president of the Great Alliance for Oral Health Across Borders, where she has been doing a fantastic job and developing leadership in global oral health with young dentists. She is also a commissioner on our Commission of Accreditation here in the US. So she has been also contributing to CODA, which is a really important job. She has been a consultant to the National Academy of Sciences, Medicine, and Engineering on the advisory to the board of the New York County Dental Society, and among other activities. She has also served as the first woman president of the New York State Dental Association and been active in councils and committees within the ADA. She has received the Jeffrey Dallin Volunteer Award for Distinguished Service from the American Dental Association, which is related to her Give Kids a Smile community work in New York City, and received a proclamation from the State Assembly of New York for contributions in the field of oral health for all New Yorkers. Deborah has additional experience in hospital dentistry, academia, other foundations, and board positions, and importantly, the general practice of dentistry right here in New York City. She has also received honorary fellowships that include Fellowship of the American College of Dentistry, Fellow of the International College of Dentistry, Fellow of the Academy of General Dentistry, uh, Fellow of the Pierre Fauchard Academy, Fellow of the New York Academy of Dentistry, and Fellow of the International Academy for Dental Facial Aesthetics. Deborah, thank you very much. The floor is yours.
Hi. Um, Thank you, Fernando. I really appreciate your kind words. Um, Welcome to all who have taken the time to join us here in New York City and virtually throughout the world to hear our distinguished speakers and the important conversation regarding oral health in the context of non-communicable diseases. I was approached this summer to work on an oral health side event to the fourth UN high-level meeting on non-communicable diseases by officers of the World Federation of Public Health Associations Oral Health Work Group. Though seemingly very different organizations, there was something valuable that we did have in common, and that is the fact that we both had achieved the position of a civil society organization with consultative status within ECOSOC, the Economic and Social Council of the United Nations. Civil society organization with consultative status is a non-government organization that has earned a role in formal UN deliberations. National NGOs, nonprofit, public, or voluntary organizations are all eligible to apply for that status, and specific criteria regarding their global involvement have to be satisfied to achieve that status within the United Nations. We decided to reach out to other UN civil society organizations we knew to see if we might be able to develop into an even larger voice for oral health at the UN General Assembly this week. Another of our goals was to help educate UN representatives that have traveled from around the world to participate, debate, and vote on issues within this week's General Assembly. There was much greater interest than we expected, and the event collaborators grew, which is seen by the impressive number of logos on our flyer. Even non-civil society organizations asked to be included. And so we developed a new kind of collaboration, the first civil society multi-stakeholder event to expand awareness of oral health and its contributions to total wellness. In setting up this event, we strive to create a space where civil societies of all kinds can explore strategies to increase recognition of oral health within the category of non-communicable diseases. Our title became Mouth Matters, Civil Society Drives Health Through Oral Health, or just Mouth Matters if you're in a rush. Fortunately, outstanding colleagues that we've worked with before and are connected to us in various ways stepped up to the plate to share their knowledge and insights with you today. You will see that these disparate guests have highly significant stories to tell that will no doubt shape your thoughts, inspire you into action as they have all done for me in the past. We are so pleased that we have many significant dignitaries from all over the world in attendance, both here in the room and online, coming to educate themselves on this important matter. And we truly appreciate that you thought it was important to come and hear our presentation. Our agenda today will move forward as follows. After introductions, we will proceed to our three internationally known keynote speakers. After this, we will have 3 additional panelists join them on the stage for Q&A. Please hold all your questions for the keynote speakers until the panel convenes. Following the panel and audience discussion, there will be concluding remarks by Dr. Lois Cohen, a highly acknowledged participant in the development of global oral health, and you will hear more about her unusual background later before she speaks. Before we begin the presentations, I would like to share some information. This event is being hosted jointly by 2 schools, College of Dentistry and the School of Global Public Health at NYU. Our utmost thanks to Dr. Fernando Hugo, Chair of Epidemiology and Health Promotion, as well as the Dean of the College of Dentistry, Dr. Charles Bertolami, have been instrumental in arranging all our logistics. Special thanks to Dr. Kieran Nagdeo, who has been a great partner in the creation of this unique event, and I'm pleased she will be able to join me as UN representative for the Alliance for Oral Health Across Borders at the UN later this week. Thank you to all our volunteers working in person and the one online from Canada for all your contributions. They have been so helpful. Many of you really put yourself out on the line, and even this morning, it was great having you around. And next, it's time to move forward with our program, and it's my pleasure to introduce our moderator of the day, my esteemed colleague, Dr. Vera Tang. Vera earned her DDS from NYU College of Dentistry with honors and completed her certificate in periodontics and master's in dental science from the University of Florida College of Dentistry. She's a diplomate in the American Board of Periodontology and a fellow of the International College of Dentists and the American College of Dentists. Additionally, she's a member of honorary societies such as Omicron Kappa Upsilon and the New York Academy of Medicine. She's currently assistant clinical professor, vice chair, and director of predoctoral periodontics in the Department of Periodontics and Implant Dentistry, NYU College of Dentistry. In addition to her academic roles, she maintains a private practice in Manhattan, specializing in. She's held leadership roles in numerous organizations and lectured widely, both nationally and internationally. And she's a past president, Northeastern Society of Periodontists, and the NYU College of Dentistry Alumni Association. She currently serves as the president of New York County Dental Society, where I have enjoyed working with her for many years. Vera, I'm pleased to hand the program over to you to introduce our next speaker.
Sorry, you're going to see me popping a lot today.
Good morning, everyone. It is my honor to be moderating this morning's important event, both online and in person with you today. It is my honor to be introducing our first keynote speaker, Dr. Steve Perlman. He was kind enough to work with us during COVID, and we did some programming together with the Alumni Association, so I'm very excited to see you back. Dr. Steve Perlman is a clinical professor of pediatric dentistry at Boston University Goldman School of Dental Medicine, and adjunct professor of Division of Pediatric Dentistry, University of Pennsylvania School of Dental Medicine. For the past 50 years, he's devoted much of his private practice, as well as teaching, to the treatment of children and adults with physical, intellectual, and developmental disabilities. In 1993, Dr. Perlman founded the Special Olympics Special Smiles in 1994, the Healthy Athletics Program. It is now the largest public health program in the world for people with intellectual and developmental disabilities. In 2002, Dr. Perlman co-founded the American Academy of Developmental Medicine and Dentistry. He is the past president of the Academy of Dentistry for persons with disability, past president of the Academy of Dentistry for persons with disability, the Massachusetts Academy of Pediatric Dentistry, and the American Academy of Developmental Medicine and Dentistry. He has published widely over 300 articles, co-edited a textbook treating the dental patient with a developmental disorder, and was a contributor to the Surgeon General's report on oral health in 2001. He has written chapters in several textbooks. Dr. Perlman is currently the president of People Advocating for Optimal Health, and he is also the co-founder of Helen, the Journal of Human Exceptionality. Please join us on stage.
Okay, thank you, everybody, for having me here today. So I am actually representing three civil societies, Special Olympics, the American Academy of Developmental Medicine and Dentistry, and People Advocating for Optimal Health. And so, like it was introduced, I'm proud to say that I started when I was asked by the Kennedy family to create a health program for the athletes of Special Olympics, of which we have 5 million athletes in 172 countries. When I was asked to create that health program, I started with dental because of my relationship with the Kennedy family. Rosemary Kennedy was my patient at one time. And so the Eunice Kennedy Shriver and the family asked me to create as you know, Special Olympics was a sports, fitness, and self-esteem program for people with intellectual disabilities globally. But I was able to introduce health because the athletes all suffered from inadequate health care. And so we created, and working with the CDC, we've screened and entered into the healthcare system over 500,000 athletes. And the data that I collected from the program, because we were sanctioned by the CDC, it was standardized data collection. So many of the countries in the world were using our data and are currently using their data. And so having a 50-year career in special needs, and then working with 30 years and working with Special Olympics, I saw that as I traveled around the world and met with ministries of health and chief dental officers of countries, that I could never move the bar in an oral health program. And so I joined colleagues of mine, physicians. 22 years ago, we founded the American Academy of Developmental and Medicine and Dentistry. We started with physicians and dentists, and now we're OT, PT, the entire village that it takes to take care of somebody with an intellectual disability. And the beauty, and I realized that if I just rode the oral health program, oral health alone, I could never get to the promised land. We could never, as kids and as adults, were denied whatever it was, whether they were denied organ transplants or access to care. If I didn't ride that physician's horse, I wouldn't get where I was today. And so, and the beauty of ADMD is that we're pirates, that we're 200 specialties in medicine, bureaucracy that's unbelievable. And when somebody is denied an organ transplant to somebody has to act right away to help the families and caregivers to get it. And so AADMD has been the quick reactor. So I'm most proud of that. So today, like I said, I'm representing these three civil society organizations and proud to do it. And if I had to give a title to my presentation today, it would be, we have met the enemy and the enemy is us. Because we, as healthcare professionals, have known about the inadequate, about the poor healthcare that people with intellectual, developmental, and physical disabilities get throughout the world. And we have stood by the sidelines and not done anything about it. And I'm here and I as a guest to my training was in private practice, but I've become a public health person through the 50 years, and I'm outraged at how we don't need any more studies and we don't need any. This population is an invisible population that lacks the ability to access and receive quality health care. So worldwide, we know there's at least 1.3 billion people with a disability. 200 million people have an intellectual disability. And I don't have to tell you, you all read about it the other day, 1 in 31 children in the United States has autism spectrum disorder now, 1 in 31. And we can't even, in the United States, we talk about 52 million Americans with disabilities. The government reports 7.5 million with intellectual and developmental disabilities, but that number is so far off. It's really 13 million because under the age of 5, we only count deaf and blind children. And so that's a census problem, and we haven't been able to fix that. But I'm here to plead for the better healthcare and access for this population. So we define the gold standard of defining what, because there are many different definitions of intellectual and developmental disabilities, but the American Association of Intellectual and Developmental Disabilities, this is the standard of definition that we use most of the time when we report it in the literature and everything we talk about today. So 50 years ago, when I started in this field, if you wanted anything to do with dental care for people with disabilities, you could only go the pediatric route. There was no such thing as general practice residencies, advanced education. So if you didn't want to be a pediatric dentist, there was no role for you. So I had to do the pediatric dental route for this. So 50 years when I started out, oral health was the #1 unmet healthcare need for people with intellectual disabilities. And 50 years later, it's still the same. We haven't been able to move the bar very much. So why does this population have the highest burden of disease? We know that they have the highest incidence of chronic illnesses like cardiovascular disease, asthma, diabetes, stroke, and obesity. We know that they receive fewer preventive services than any other population, and they have more difficulty in accessing healthcare. In the study, the only study that I really know that has the best data came out of the United Kingdom. And if you have an intellectual disability in the you're going to die 13 years. If you're a male, you're going to die 13 years earlier than your neurotypical counterpart. And if you're a female unconscious, you're going to die 20 years earlier than your neurotypical. And you don't die of the same things. But why would an intellectual disability matter in the lifespan? But look at this horrible data. And we know that women aren't getting adequate gynecology exams, breast exams. And so that accounts for the huge discrepancy between male and female longevity. We know that the amount of abuse in this population is incredible, higher rate and subject to violence. And this one, I didn't even realize until I got into this lecture that a third to a half of people killed by law enforcement officers have an underlying disability. So we all know, you're all public health people, we know about the social determinants of health, a higher rate of poverty, decreased access to care. Many adults in the world live in group homes and congregated settings, and the isolation can lead to poor mental health as well. And this is another thing that's really important, ableism and implied bias. All the recent studies by physicians with disabilities that in the medical profession, they look at people with disabilities as not worthy of their care, or they don't have the quality of life. And what is happiness with somebody with an intellectual disability? People can't define it. So so not only did they get the discrepancy amongst the population, but also within the medical and dental population. They don't think that their population is worthy of the care or their time. Okay, what are the barriers to dental care that make it the most #1 problem, oral health problem that they have? Lack of education and training of dental profession. When I started my journey with Special Olympics, we looked at what are dental students, because that's the most common thing. Everybody says, no training, no training. So when we first started, we looked, and 30 years ago, there was nothing in the Council on Dental Accreditation. There was no requirement that dental students require anything about people with disabilities. Nothing. And a letter with Eunice Kennedy Shriver at the time, Dakota, and we petitioned the Council on Dental Accreditation, and we said, you know what? There's nothing in the curriculum. Must be a mistake. We think there might have been something in there, and then they took it out. It took us 3 years to get anything in the Council on Dental Accreditation, and the feedback was because, oh, okay, sorry, guys. And so Council, year 1, refused. Year 2, refused. Year 3, what is wrong? Why would the dental profession not want to put anything in the curriculum about people with intellectual disabilities? The feedback was, we don't have the faculty and we can't make any money on the patients. And so it took us 3 years to get a regulation that dental schools would be required to teach something about people with intellectual disabilities and disabilities. And they refused to put competency in it. It was only students could graduate with the diagnosis and treatment planning. The dental schools in the country refused to put anything about hands-on training. So why else? Barriers to care, regulations. Another big comment, lack of reimbursement in finances, because many of them are at the poverty level and they require public assistance, so they don't have the money to pay for it. And the dentists and healthcare dentists don't have this population just takes more time to treat, oftentimes communication problems and everything. Follow-up care. Oftentimes the Medicaid systems, wherever you are in the world, they may pay for that intake visit to get the patient out of pain or something, but there's no follow-up care. You can do an extraction and then there's no follow-up care. Do we know that the parents or caregivers or group homes are going to follow up with the antibiotics and everything? No, the system doesn't pay for follow-up care. Access to offices, the stigma about treating a posture, these people are not worthy. Oh, I'm a cosmetic dentist and they don't realize what I'm doing. So stigma, communication difficulties, and the problems of the population that takes care of this population. They often rely on direct support personnel. It's a very low, no matter where it is in the world, it's a low-paying job with not much career opportunity. It's not very glamorous to change the diaper of a 40-year-old or 50-year-old person. And not only that, there's such an amazing turnover. In the United States, there's a 70% turnover per year in direct support personnel working in these congregated facilities and group homes. Social role valorization. They're not worthy of my time, not worthy of my care. One of my favorite stories is of a colleague that I met who was in training with me. I trained her to work with me in Special Olympics, and she was for a pediatric dentist in Pretoria, South Africa. And she said, when my baby was born, I have 3 children, and when my baby was born, and I was waiting to hold my baby for the first time, the physician brought my baby over to me and showed me the feet first and then the face, and then said, your baby has all the characteristics of Down syndrome. It's going to be a burden on you for the rest of your life. It's going to be take away from your other kids. Let us take the child. You go home, forget that you had this child, and started, if you want another child to have another, we will take it from you. And this was not a long time ago. This was a few years ago. So this is from physicians looking at the capability of the quality of life of the family and the changing face of healthcare today. Look, now if you're in the hospital, you're getting taken care of by a hospitalist, not your old primary care physician who may know you. So hospitalists have very little training. And what we're seeing is way more frequent admissions to emergency rooms. We're seeing greater length of stays in hospitals and discharges without the actual properly diagnosed condition. And so the other reason why this population has such a high burden of disease is because of comorbidities and secondary conditions. So a comorbidity is the presence of 1 or 2 more distinct health conditions in the same person. And people with disabilities have way more comorbidities than any other population. They have seizure disorders. 25% of people with intellectual disabilities will have a seizure disorder, and almost 70% will still have breakthroughs, even though they're on the great medications that they're on. Many of them have dysphagia, swallowing problems, especially those with 100% of those with cerebral palsy. Aspiration pneumonia is the #1 cause of death, of preventable death, #1 cause of people with developmental disabilities living in the community. It's called the Fatal 5. Totally different than the neurotypical population, which dies of cancer and heart disease and diabetes related. #1 cause, aspiration pneumonia. And in the top fatal 5, constipation, one of the top fatal 5 causes of death. How preventable is that? But lack of movement, constipation, bowel obstruction, perforated bowel, death. And so, let me see, constipation, osteoporosis. It was the ADMD that discovered that, seizure medication negates a lot of vitamin D absorption. And we figured out that people with seizure disorders needed more vitamin D, and actually got the American Academy of Endocrinology to change the intake of the guidelines for vitamin D absorption. Poor oral health, like I said, #1 problem. Sensory processing disorders. Okay, all of these kids. Okay, sorry. Okay, I'm going to go through really quick because I want to cover a couple of things. Okay, obesity, mental health, spasticity, polypharmacy beyond belief, gait problems, accidents, and dementia. And also secondary conditions, way more frequent than the neurotypical population, skin breakdowns. Everybody with Down syndrome has sleep apnea, pelvic pain in women, behavioral issues. I apologize for this. The other big problem in our world is diagnostic overshadowing, that because of the lack of experience and training and exposure of healthcare providers, that they don't understand, and because usually behavior, somebody can be on psychotropic drugs and well controlled, and all of a sudden the behavior changes. And so when the report goes to the family, to the group home, whatever it is, behavior changes. So it's always increasing psychotropic drugs because it's a behavioral problem. So wrong, because usually it's the underlying medical diagnosis, earache, menstrual cramps, whatever it is that's causing a toothache, a simple thing but because of the physicians in the medical care, it's like, oh, they have autism, so everything's related to that. And then baseline exaggeration, which is another term that you need to be familiar with. So besides the fact that they have the highest burden of disease, the public health people have been by the sidelines and never helped us to move the bar forward. So I'm appealing to you as public health professionals to please put this invisible population on your radar screen. And I just want to end with infant oral mutilation, because 5 years ago, I got a call from the Global Children's Oral Health Fund, and Dr. Ramon Betty, who's the Chief Dental Officer of UK. And he said, Steve, with your connections with Special Olympics and all over the world, you must help us end infant oral mutilation in Africa. So everybody's probably familiar with female genital mutilation, but infant oral mutilation is practiced throughout Africa today. There are other names for it. These are other names that you may have heard, but prevalence of infant oral mutilation in Central and East Africa, thousands of children, neurotypical children, but tens of thousands of children are dying each year from this barbaric practice. And where is the World Health Organization? And where is the dental profession? Because the dentists in Africa reached out to me to help them because they're having trouble. So what is infant oral mutilation? They gouge out between 4 and 18 months. Tribal healers gouge out the primary cuspid buds because they look when they enucleated, and children in Africa die of diarrhea and infection. And so tribal healers, there's no access to physicians and medical care, so it's basically tribal healers that are providing the care of healthcare in the villages. And so they perform this infant oral mutilation, and the person who I'm working with visits every week. He visits hospitals where dozens of children are dying from this procedure. The tribal healers use they use nails, bicycle spokes, razor blades to enucleate the cuspid buds. This is what they look like. The children, why do they die? Because they pack, after their surgery, they pack the healing with dung or reptile, with all these crazy things. And long-term effects of infant oral mutilation. This is what it looks like, a child with infant oral mutilation. And basically, this is a huge public health issue, but it's also a child abuse issue. And so if our role in public health is to improve the health and safety of these communities, why is this practice still being allowed to exist? So how we address it is we have to do it at the community engagement level. But in June, the point I want to make here is that because I've heard from other people, well, it doesn't seem to be that much of a problem, doesn't seem to be that much of a problem. But in 2019, the chief dental offices of all the countries in Central and Eastern Africa got together and passed this Addis Ababa Declaration, all signed by the chief dental offices, to please help us end infant oral mutilation in our regions. 10-year plan, 5 years into it, nothing done. Where is the public health organizations on this? Where is the World Health Organization on this? In the United States, we had one child, Diamante Driver, that died because of access to care. And what you hear is only the partial story. Diamante Driver had access to care. It was because of his disability and ADHD that nobody would treat him because he was a difficult patient. And that's I didn't spend enough time on it, but behavioral issues are the biggest barrier to care today with access to dental care and stuff like that. So we want to help the chief dental offices of this union. So I'm appealing to you as this is a public health issue. And because I've reached out and I said, because I've been told that the healers they support themselves by doing this. And so I said, well, how much did he really make by doing these infant oral mutilations? They either get a dollar or a chicken. And is the life of a child worth a chicken that we have allowed this thing to exist today? Thank you, everybody.
We'll do a quick AV check because those online can't see the slides as well as we can. So we'll take like 2 minutes for that. And we'll have Dr. Aurora join us. She's in London. She just landed and she's joining us online. So we're going to have her go next. And thank you, Dr. Ryan, going after. So I'll just do this quickly.
Dr. Perlman, thank you for the insightful lecture. It was truly eye-opening, and I have been a dedicated volunteer for Special Olympics since I was a dental student, so thank you. Next, we have Dr. Monica Aurora, a public health scientist who's joining us all the way from London. She's working in the area of health promotion, non-communicable disease, prevention and control, and child and adolescent health and oral health. She is the Vice President of Research at the Public Health Foundation of India. She is the immediate past president of NCD Alliance and the founding chairperson of the Southeast Asia NCD Alliance. She serves on several national and international expert committees on nutrition, NCDs, ending childhood obesity, and has been a commissioner on the Lancet Commission on Adolescent Health. In 2016, and she is currently the site PI for the National Health Research Priority Project, implementing research on promoting oral health through school-based toothbrushing intervention. She has been honored with several best practice awards in child and adolescent health, including Global Health Council, the Society for Adolescent Health and Medicine, and the World Health Organization, to name a few. Please join me in welcoming Dr. Aurora.
Thank you very much for that kind introduction. Am I audible?
Yeah.
Perfect. And I'm sorry, I'm presenting from the airport, and I just hope there will be no loud announcements. So as Dr. Perelman started with talking about the civil society he represents, I represent 4 civil societies here: the Public Health Foundation of India, Hriday, which is the Secretariat for the India NCD Alliance, the Healthy India Alliance, and Southeast Asia NCD Alliance. So very pleased to be amongst a group of very knowledgeable and committed oral health specialists and public health advocates. What I'm going to talk about is mostly about our experiences with non-communicable diseases and why we have been feeling that there is this need for integrating oral health with NCD agenda, and especially given the UN high-level meeting this coming week. Can I get the slides on? Okay, while the slides come up, I'll start. Kiran, you want me to start? Okay, yeah. Okay, we can go to the next slide. Okay.
Sorry, Doctor. I'll just start switching your slides now.
Yeah, next slide, please. So as I said, I am actively involved in NCD prevention and control research as well as implementation. And oral diseases have been an integral part of our work, considering that they are the most common non-communicable disease worldwide, affecting 3.7 billion people, which will be very well known to the audience here. But I wanted to emphasize that the condition which is common between NCDs and oral health is that these are largely preventable. Yet, the most neglected NCD in policy, integration with other health systems, and also in the political declaration, it is essential to include oral health from the equity and the universal health coverage perspective. Also, considering that untreated caries in permanent teeth, untreated tooth decay is affecting about 2.5 billion people. Severe gum diseases affecting about 1 billion people around the globe, and complete tooth loss affecting 350 million people, with cancer being common amongst NCDs and oral health. Again, I will be drawing a lot of parallels why we need to emphasize on NCDs to integrate oral health into the political declaration as well as the national programs. Next slide, please. Here, I just wanted to emphasize that the combined estimated number of cases of oral diseases globally is about 1 billion times higher than the cases of all 5 main NCDs that the world would be talking about during the coming week. But when we put all of them together, the burden of oral disease is much, much higher. And oral diseases disproportionately impact people from low and middle income country and marginalized populations because their access to health promotion and oral health care is very limited, but also because there are a lot of cultural factors and myths as well as beliefs which do not give great importance to oral conditions. Also, oral conditions account for the 4th highest healthcare expenditure when compared to other non-communicable diseases. Therefore, something during this week we have to continue to prioritize and emphasize on. Next slide, please. This is the evolution of the NCD framing. It started with 4x4 framework with 4 risk factors which were affecting all the 4 non-communicable diseases across cardiovascular disease, diabetes, cancers, and chronic respiratory diseases. This was later expanded to include mental disorders as the 5th NCDs and air pollution as the 5th risk factor. And there are now proposals to go beyond the 5x5 framework, as is also apparent from the political declaration, to go to 6x6, where oral diseases and conditions are to be identified as the 6th NCD and sugar as a common risk factor with NCDs. So this expanded 6x6 framework has been proposed recently, and we really hope that we see prominent spaces and prominent action plans as well as indicators included on this 6x6 framework, especially around oral health. Next slide, please. So association between oral health and common NCDs is very apparent. There are a lot of studies and evidence, whether we talk about hypertension or people with diabetes having poor oral health and more severe caries, also greater attachment loss. Even with mental health, people with severe mental illnesses have about 2.8 times higher odds of complete tooth loss compared to the general population. Next slide. So just to emphasize that we just see a very close association between NCDs and oral health, and by working on intervening on the risk factors, we would surely have impact on reducing the burden of non-communicable diseases, but also in promoting oral health. Also, this slide underscores that years lost to disability is going to be very high for oral conditions. So this would go up the ladder when we talk about leading conditions, which would be affecting humans worldwide and their projection for 2050. So just to again underscore that a condition that we cannot ignore to work on. Next slide, please. The common risk factors of tobacco, alcohol, diet, and particularly sugar and its association through the both smoking and smokeless forms of tobacco, oral cancer, oral mucosal lesions, periodontal disease, and dental implants. Again, lot of evidence emphasizing that in this part of the world from where I come, India, Southeast Asia region has a lot of smokeless tobacco use, and countries like India have smokeless tobacco use as the predominant form of risk factor causing oral cancer cases. Similarly, for sugar-sweetened beverages, higher consumption levels have significantly increased the risk of dental caries and dental erosion. So again, common implementation plans would provide dual benefit for NCDs and oral health. Next slide, please. Also looking at risk factors from the oral disease perspective, we see very high per capita availability of sugar, current tobacco use, and also per capita alcohol consumption, which need to be looked at from the National Health Programs perspective and to be included in National NCD Action Plan as well as Oral Health Action Plans. Next slide. The absence or presence of oral health has significant economic impact. Optimal oral health has been linked to employability and increased productivity. So these figures are highlighting that productivity loss due to 5 oral diseases is about 7,249 million dollars, which makes it very, very important that health system starts acting on attending oral health to be able to reduce not only out-of-pocket expenditure, but also expenditure on dental health care. Next slide, please. Just to highlight India country profile, and here I wanted to highlight that oral health needs to be attended from a very early age in children, that is from 1 to 9 years, because the untreated caries impact the deciduous teeth, and we need to adopt a life course approach. And also to emphasize on the lip and oral cancer, which is something I highlighted, that this is an area of great concern for our policy making because of the oral tobacco use. Next slide. Dr. Perelman did talk about the social and determinants of oral diseases, and same holds true for NCDs as well. But I would also like to emphasize on commercial determinants and the industry strategies which need to be looked at when we talk about risk factors like alcohol consumption, tobacco, or other risk factors of ultra-processed food intakes leading to obesity and also oral health deterioration. Next slide. This is interconnectedness of risk factors with diseases across NCDs and oral health. Therefore, just to emphasize that we need to work on political environment, we need to work on social determinants, commercial determinants, so physical environment also needs to be addressed through policy interventions. Next slide. So this is the interconnectedness of oral health, which is not specifically mentioned or targeted in the SDG 3. However, oral disease and the common NCDs have these coexisting modifying risk factors. In addition, oral health is associated with social, economic, cultural, environmental problems that I had mentioned. And by implementing a three-pronged approach of oral health promotion, oral health care, and universal health coverage, these could not only be good for oral health, but also benefit general health and well-being. Next slide, please. We are all well aware of the progress that has happened in the past few years on prioritizing global action on oral health, starting with the 74th World Health Assembly, underscoring community-based interventions and stronger oral health agendas, followed by the Global Strategy and Action Plan on Oral Health, where the vision is universal health coverage for oral health by 2030 and a target of 80% population with essential services to be covered and 10% reduction in major oral diseases. Similarly, Bangkok Declaration emphasizes on adopting the integration of oral health into the primary health care approach and UHC benefit packages. So, very appropriate time to be able to talk about integration not only in NCDs but overall in health programs. Next slide. So just to quickly talk about the quality of life, because oral health related quality of life is a multi-dimensional construct that reflects people's comfort while eating, sleeping, and engaging in social interaction, their self-esteem, their satisfaction with respect to their oral health, and the personal consequences of chronic untreated oral diseases are often severe and can include chronic pain, sepsis, reduced quality of life, in children, particularly lost school days, and even academic performance, and disruption to family life and decreased work productivity. So, seeing this scenario, the Government of India, Indian Council of Medical Research, has recently launched a National Health Research Priority Project, which is an implementation research on promoting daily toothbrushing in school settings through supervised toothbrushing by school teachers. And nutrition lectures and modules are very much a part of that integrated framework. Next slide. So just to emphasize that solutions are common, and in fact, most of them are largely preventable, whether we talk about NCDs or oral health. Next slide, please. I have just done a quick analysis in this on what is in the political declaration and what needs to be done. So just to talk about that there is shift from recognition to action globally on advocacy required for oral health. Oral health is both an NCD issue and a rights-based issue as well, so requiring strong accountability. And the world has moved from ignoring oral health to acknowledging it to planning action. And now it's about delivery. Next slide. Um, Here we have some recommendations, again, from various policy briefs by oral health prominent associations and also by the NCD organizations. Now is a critical opportunity and moment with upcoming UN high-level meeting to be able to propose this integrated, accelerated action plan for oral health and NCDs. Oral health must be integrated into SDG 3.4 and 3.8, essential for reducing NCD mortality and achieving UHC. Indicators like caries reduction, school days lost, or urgent oral care access to measure real progress. Financing is going to be a game changer. So fiscal policies on sugar, tobacco, alcohol can fund oral health programs around the globe. PHC, which is the primary health care, and UHC benefits must include oral health as an essential service, and civil society must continue to push governments to advocate for oral health as human right and demand oral health data in monitoring frameworks. So oral health is no longer optional, it is integral to achieving health for all. Next slide. So in conclusion, I would just like to say and reiterate what we all know. No health without oral health, and UNHLM is our opportunity to make oral health visible, measurable, and funded within the global NCD agenda. Thank you.
Thank you, Dr. We might call you back after when the panel is open. Um, Feel free to do your thing at the airport. We'll go back and invite Dr. Tang again. I'll just stop share for a second. Thank you, Dr.
Thank you. And our next presenter is, I'd like to introduce Dr. Maria Ryan. She is the Vice President and Chief Dental Officer at Colgate-Palmolive Company, where she provides oversight and leadership to dental and dermal clinical organizations, knowledge management, scientific communication, and the biosolution team. Dr. Ryan previously served as professor and chair of the Department of Oral Biology and Pathology at Stony Brook University, where she was actively involved in teaching, clinical practice, and research. She's a past president of the American Association of Dental Research. Dr. Ryan received numerous awards, including NIH National Research Service Award and Physician Scientist Award. She's the recipient of the New Dentist Leadership Award from the Dental Society of the State of New York and received achievement awards from the American Dental Association. Dr. Ryan was a first recipient of the Victress Health Award, which she received in Berlin, Germany in 2010 to recognize her education and research efforts in the area of women's health. Dr. Ryan is a distinguished alumnus of Stony Brook School of Dental Medicine and was a fellow of the Hedwig van American Elam program for women at Drexel University College of Medicine. Dr. Ryan is nationally and internationally known speaker and author who has appeared in multiple media outlets and discussed the role of dental professional in the provision of optimal overall healthcare. Please welcome Dr. Ryan.
Thank you, Dr. Tang, for the kind introduction, and to Dr. Weisfuse and Nagdeo for organizing this great side event here, and to Dr. Bertolami for hosting us here at NYU, and to our previous speakers, Dr. Perlman and Dr. Aurora, for giving some great information to all of us. So I have a tough act to follow here and not too much time. So let's see if I can, how can I go, it's not forwarding. Maybe I'll try this one. Hold on. Oh, so we have that one. That's back. It's not forwarding. I tried this. All right. So what do I press? In this case, we're back. Is this one for forward? Forward, okay. Okay, do you want to go back? Okay. Okay, so what we'll be talking about is what we call reimagining a healthier future for all. At Colgate-Palmolive, I am at the Colgate-Palmolive Company, for full disclosure, an employee. And we'll be talking about getting oral health onto the global health agenda, addressing the root cause of why we may or may not be there, and the power of partnerships. So for me, today's question is, what would it take for patients and their communities to be empowered to improve their oral health and have equitable access to oral health services? And certainly getting oral health on the global health agenda is very important. And connecting oral health to general well-being, I believe, is an important way for us to get there. And we've heard about that from our previous speakers, the connections between oral health and overall health and well-being, and the fact that addressing oral health can lead to cost-effective care. It's been mentioned already that oral health is critical to overall health and well-being, and that 3.7 billion people worldwide suffer from oral diseases. In particular, I am a periodontist, so I have a keen interest in periodontal disease, and about 50% of the world's population suffers from some form of periodontal disease, with severe periodontal diseases affecting about 19% of the global adult population, representing more than 1 billion cases worldwide. Why is periodontal disease so important? It's important because it's a disease of infection and inflammation. And when we talk to any physician, they will tell you that infection in a patient needs to be addressed. Inflammation needs to be managed. So the treatment of periodontal diseases should never be considered an option or elective. And in fact, periodontal disease is the most common chronic inflammatory condition in the world. So we must address the infection and inflammation that exists in so many people throughout the world. And unfortunately, it's an often silent disease. So many people may not actually know that they have periodontal disease until it's very far advanced. So what about the impact that oral health has on the rest of the body? We've heard about many, many connections, and I'm going to just focus on 4 of them quickly because I don't have much time. So we'll talk about diabetes and cardiovascular disease, adverse pregnancy outcomes, and respiratory disease. If you think about the research on the connections between oral and overall health, there is more clinical evidence than ever connecting oral health to overall health and well-being. There are nearly there are over 468,000 scientific articles on this, with 80% of them being published in the last 10 years. And when we look at the associations between systemic conditions and periodontitis, there are areas that have a lot of publications talking about the biological plausibility, the strength of the association, the effect of periodontal disease on systemic health, and the effect of the treatment of periodontal diseases on overall health. So as I said, we will focus on just a few. So we'll start with diabetes and cardiovascular disease because they are global epidemics, and they are currently among the leading causes of morbidity and mortality throughout the world when you look at this top list of diseases. When it comes to diabetes, we recognize that untreated periodontal disease makes it harder for people with diabetes to manage their disease, to reduce their blood glucose levels, to reduce their A1C levels. And we also recognize that in people with diabetes, they are more likely to develop periodontal disease, 3 times higher risk of developing it. So it's a two-way street here. And so it's very important that we address periodontal disease as a risk factor for even the development of diabetes and for the management of diabetes. And so why does this bidirectional association exist? Well, first of all, if you have diabetes, you have elevated blood glucose, you have elevated levels of AGEs, advanced glycation end products, that interact with their cells to drive inflammation. So people with elevated blood glucose are at greater risk actually for developing periodontal diseases, as we mentioned before. And in people with periodontal disease that have bacteria in their mouth that we can get dissemination of throughout the body, and they have inflammation, that will drive insulin resistance and it will alter insulin secretion. So it makes it much more difficult for a person with diabetes to control their diabetes. We do know that if you treat periodontal disease, it can have an impact. It can have an impact in reducing hsCRP, which is a marker of systemic inflammation. So if you have periodontal disease, you have not only inflammation in your mouth, but you can get systemic inflammation that's elevated. If you treat that periodontal disease, you can reduce the levels of hsCRP within the system. So therefore, you improve on that insulin resistance, insulin secretion by driving down that inflammation. You can also reduce A1C levels, and there have been many publications, many reviews, and one of them states you can reduce it by about 0.5. 0.5, if you think about it, is an average. We can see in patients a 1% reduction. We can see lower, we can see higher, right? 1% reduction, according to UK-PDS study in type 2 people with diabetes, can result in a 14% decrease in the risk for a heart attack in a person with diabetes. And that's what kills, unfortunately, most people with diabetes. There's also an impact that we see of periodontitis on cardiovascular health. And we know that deferred dental care is associated with elevated blood pressure and an increased risk for hypertension, and that periodontitis is associated with unsuccessful attempts to treat hypertension with medication, and that periodontal disease increases the risk of a first heart attack by 28%. How does this happen? Well, if you think about what drives cardiovascular disease, it's often driven by endothelial dysfunction, and this will lead to atherosclerosis and thrombosis. What drives endothelial dysfunction? Inflammation, and we've been talking about periodontal disease being the most common chronic inflammatory disease. In people with diabetes, they actually have chronic inflammation because of this age-range interaction. And all of this and other risk factors listed here will drive endothelial cell dysfunction. So physicians actually measure this endothelial cell dysfunction by looking at flow-mediated dilatation in the brachial arteries, intermedial thickness of the carotid artery. And what we know is that if you treat periodontal disease, you can improve on flow-mediated dilatation. That's a great thing. It reduces risk for heart attack. And it's really not a very costly intervention when you think about it. And so if you treat and this is with non-surgical therapy, it's called intensive non-surgical therapy, which is scaling and root planing and the use of a locally applied antimicrobial in this case. If you look at the impact of periodontitis on intimal medial thickness, the worse the periodontal condition, the more intimal medial thickness. So the higher your risk for heart attack and stroke. So we know that periodontitis can really have an impact. We now talked about diabetes, we talked about cardiovascular disease. We also know it has a significant impact on respiratory health, and it puts people at risk for respiratory diseases or exacerbates existing lung conditions. The oral flora can harbor the respiratory pathogens. So if you have advanced dental cleaning, it significantly reduces chronic obstructive pulmonary disease exacerbation and frequency. And COPD was on that top 10 list for mortality. Standard ventilator-associated pneumonia frequency is about greater than 25%, but the use of antiseptics and good cleaning in the oral cavity reduces it to 18%. And when we think about patients with ventilator-associated pneumonia whose teeth were regularly brushed, they spend significantly less time on mechanical ventilation than other VAP patients. So reduction in costs, reduction in hospital time, improving oral hygiene amongst medically fragile seniors, reduced death rate from aspiration pneumonia. And we heard from Dr. Perlman, a leading cause of death, right, in people with disabilities. So it's important to have a clean mouth. And finally, for adverse birth outcomes, periodontal disease during pregnancy is associated with preterm low birth weight and preeclampsia, a pregnancy complication that can cause organ damage and can be fatal. And if you think about the presence of periodontal disease, it has a 40% prevalence in pregnant mothers. And 50% of women develop gingivitis during pregnancy, being more vulnerable to periodontal disease than non-pregnant peers. And so pregnant women with periodontal disease have a 1.57-fold higher risk of preterm birth and a 2.43-fold higher risk of delivering low birth weight infants than pregnant women with a healthy periodontium. And that also leads to significant hospital costs, et cetera. So it needs to be addressed during pregnancy. And if you look in the medical literature, when it talks about preterm birth, it talks about infection and inflammation driving that. And so periodontal disease can certainly contribute to preterm birth. So results of individual randomized controlled trials suggest that certain periodontal treatment strategies, the use of scaling and root planing and chlorhexidine, can reduce the risk of preterm birth and low birth weight. And systematic reviews highlight the need for more high-quality studies, and maintaining good oral health is a crucial part of overall prenatal care, regardless of the direct impact on preterm low birth weights. Many studies have been done over the years. This is one that was done a number of years ago with insurance carriers that have both dental and medical insurance. And certainly it has been found that managing periodontal disease can lower annual medical costs for all of the populations that I just described, and that treating periodontal disease reduces hospital admissions. Much of this data and much more on the $700 billion a year that is lost because of the need for treatment of oral conditions. That's about half of it. The other half is, Dr. Aurora mentioned, lost productivity, all the other factors that we see that happen when people are not managed for their oral conditions. It can be found in a white paper that was put out by the World Economic Forum, the Oral Health Affinity Group, which I co-chair with Ali Neal from Henry Schein, Marco Vujicic from the ADA. And if you go to the QR code, you can get the information from that paper that many public health officials have used to highlight the impact of poor oral health on the global economy and advocate for a positive economic impact of good oral health for the world's economy, to increase awareness of the oral health crisis and the disparities of care for underrepresented groups and its impact on public health, and to encourage corporations and public health systems to incorporate oral care provisions into their healthcare agenda, and to get oral health on the global health agenda. The 4 actions that the paper concludes with is adopting health financing policies that improve coverage, access, and affordability of oral healthcare services, particularly for deprived, disadvantaged, and vulnerable groups. Developing innovative health and oral health workforce models, including training and remuneration that allow for flexibility in addressing oral health needs. Promoting healthcare service delivery models that integrate oral healthcare services into primary, secondary, and tertiary care, and implementing policies that promote upstream interventions focusing on prevention, health promotion, health behaviors versus costly downstream treatment of oral diseases. Some people ask me, why did you leave academia and go into industry? And I say, well, after looking at, the work that many of our industry partners do, I recognize the reach that industry has. And one of the issues we have is we've been, to me, trying to manage this from above. And all of us get in a room like today, well, the experts, and we talk about it. But what about getting consumers to advocate for themselves, the public to advocate for themselves? And Colgate is in 6 out of every 10 homes. So I said, this could work. So I saw that they have a commitment to oral health and to teaching people about oral health since 1911. So they've been around for over 200 years. Oral health education has been a tradition of the company with a commitment since 1911 in teaching people about oral health. One of the programs that we have, Bright Smiles, Bright Futures, is a far-reaching, impactful education initiative with a goal of improving oral health and well-being of children and families around the world. This is a flagship program which has been around for greater than 30 years with a mission to connect underserved communities to oral health education, free dental screenings, and treatment and referrals. It's in over 100 countries and it has been translated into 40 languages, where we have teachers actually teaching their students, teaching their parents early on about the importance of oral health. We have reached now 2 billion children and families, which we are celebrating this week at a side event at the UNGA meeting here. And we have over 2,000 partnerships with government, dental professionals, NGOs, and the community at large. I'm happy to put this recent press release, which just came out last week, about hundreds of thousands of 3 to 5-year-olds in deprived areas of England receiving over 2 million toothbrushes and toothpastes in a major dental health drive driven by the Department of Health and Social Care in collaboration with our Bright Smiles, Bright Futures program. So we talk about collaborating between industry and governments, academia, and researchers. And also, it's really important to educate people throughout the world. And it was very interesting. I was doing an interview with Dr. Rob Califf, who ran our Food and Drug Administration, and we were interviewed by a reporter, Frank Sesno. And when we were talking about, because Rob is a well-known cardiologist, the connections between oral health and overall health, the reporter said, I didn't really know much about this. How is that? And so I said to him, well, caries and periodontal disease isn't very sexy. And so most people like to talk about white teeth. And he said, well, Maria, you need to figure out how to make it sexier so that everybody else understands. So we recognize that oral health literacy is low globally. And so I went back and talked to some of our marketers, and they said, well, your IQ or your EQ, what's your OQ? What's your oral health quotient? So we created a quiz to really allow people to do a self-assessment, and you can get it with that QR code up in the corner, of their oral health knowledge. And it's really a free interactive assessment that people can take and find out their oral health quotient. And it provides information and resources for people to learn about oral health and how to improve their OQ score. And so we've had millions of people take this quiz. It's very interesting. We've published on how you can change knowledge, attitudes, and practices by educating people. And one of the most interesting things to me is that many people don't even realize that caries is a disease. So just teaching people about the oral health conditions that they face, the diseases that they face, is important. And we can change that by educating them. And we've shown the changes in their knowledge, the knowledge about those connections between oral health and overall health that I mentioned before. Most people with diabetes said, no one ever talked to me about my teeth. And so they are learning about these connections, and they are also learning that you need actives in your toothpaste to prevent caries. You need to brush twice a day. You need to floss. So even many people do not really know the preventive strategies that they should be taking to help prevent oral diseases. And we've shown that this is working not only in the US where it started, but we have done this in India, in Latin America, etc. So we continue to work on that program. Finally, the power of partnerships. And as Dr. Perlman mentioned, we recognize that people with disabilities face significant challenges. So with the University of Pennsylvania, which has developed a personalized care suite, we have developed a laboratory for innovation within that personalized care suite, where we are doing studies to help people with autism to have better oral health, to develop new technologies that really help caregivers and those patients to have self-care. And so it was interesting. We had a connected technology with gamification, augmented reality that we had put out for children. And it was parents of autistic children who had contacted us and said, wow, this is really engaging. I've been trying to get my kid to brush forever, but they like the game and they won't stop brushing. So we said, let's do a study. So with Dr. Wolf and his team there, we did a study utilizing this gamification and found that we were able to increase the usage of the brush in an autistic population. and have them brush more often and have them help the caregivers to provide preventive strategies. So it's important to really look at each and every individual population and help them to achieve self-care, because self-care is very important to what we are trying to achieve here. We have another project, Tom, to make oral care more accessible for people with disabilities. And we have another center that we work with in Brazil, in Sao Paulo, looking at and assessing the perception of functional prototypes developed for patients with disabilities, working together with the users, with the professionals, with the caregivers to develop handles that are more useful, that they are comfortable with, and that will help them in providing oral care. So it's very important also to think about workforce diversity, patient professional concordance is something that we all know people like to go to someone who looks like them. And if you look in our country, I mean, we don't have a lot of populations that are represented. So we help to provide scholarships in many different programs, one of them with the National Dental Association, the Audacity to Dream Scholarship, and many other scholarships throughout the country to help to have more diversity in our workforce, and also to have more diversity in the research that we do through our Torch Scholarship, where we have benefited dentists and hygienists as well as others pursuing postgraduate training. And we believe that by having researchers that are a diversified group of researchers, they will focus on those communities and the needs that they have. So we continue to support programs like that. So what would it take, back to the initial question, for patients in their communities to be empowered to improve their oral health and have equitable access to oral health services? Getting oral health on the global health agenda. And that's why you're all here today. And that's why we see so many side events this week. We need to continue to be at the table. We need to continue to speak up about the importance of oral health. And we need to address root causes like low oral health literacy. We need to educate people about the things that we're talking about here today so that they demand that they get the oral health care that they need. And finally, we need to work together to create the right programs, the partnerships, and products. So let's get started, because at Colgate, we believe everyone deserves a future they can smile about. Thank you.
Thank you, Dr. Ryan, and thank you to the keynote speakers for the enlightening, insightful information, which is important for oral health. Advocacy is key, and like you said, if we're not on the menu, we're going to be we have to be at the table, otherwise we're going to be on the menu. So I think it's really important what we do as a community and bringing awareness to this. So at this point, I'd like to introduce our panel. This is your opportunity for the interactive discussion portion, and we're going to be taking some time for you, giving you the opportunity to ask some questions. So I'd like to introduce a couple of our new panelists, Dr. Abiola Adini, and she is the chair of Oral Health Working Group of the World Federation of Public Health Associations and assistant professor at the School and Global Health of Fairleigh Dickinson University of the Vancouver campus. An internationally trained dentist, academic, and researcher, she holds a PhD in dental public health from the University of British Columbia and specialized graduate degrees in population and public health from Nigeria and the UK. Through the leadership of the WFPHA, OHWG, there's a lot of letters there, I'm sorry. Dr. Ndini has been instrumental in advancing the integration of oral health and non-communicable disease frameworks, including developing policy briefs, hosting podcasts, that highlights oral health role in overall health outcomes. Her research spans in Nigeria, Kenya, and Canada, focusing on integrating oral health into primary health care and maternal and child health care systems. She serves on the board of the Canadian Association of Public Health Dentistry and contributes to advancing oral health equity through policy development and community engagement initiatives. Please welcome Dr. Adeni. Next, I would like to introduce Dr. Kiran Nagdio. As she has been our host of this event, she is a dentist epidemiologist. She serves as the vice chair of oral health working groups of the World Federation of Public Health Associations and is on the board of directors of the Alliance for Oral Health Across Borders. She attained her Bachelor of Dental Science from D.Y. Patil University School of Dentistry in India. And with 8 years of clinical experience in India, she brought a practice-informed lens to pursue her studies in public health. She earned her Master in Public Health and Global Health with concentration in epidemiology and biostatistics from the Icahn School of Medicine at Mount Sinai, New York, and is currently pursuing her PhD in Public Health and Epidemiology at the NYU School of Global Public Health with us. She also serves as the Education Board Representatives for the American Public Health Association Student Assembly and is the Senior Student Fellow in the APHA Maternal and Child Health section. Amongst awards for excellence in leadership and community service and activism, she's been inducted into the Delta Omega Honorary Society for Public Health. Please join us in welcoming Dr. Kim. At this time, I would like to also introduce Dr. Seema Kumar. She is our online moderator. She is the dental specialist at Te Marae Ora Ministry of Health in Rarotonga in Cook Island. She completed her Bachelor of Dental Surgery at the University of South Pacific in 1997 and Master of Pediatric Dentistry at Eastman Dental Institute, University College of London. She has additional postgraduate training in medical education, tertiary teaching, and orthodontics. Dr. Kumar is pursuing her doctorate at the University of South Pacific. Her interests include maternal and child oral health, reducing early childhood caries, oral health literacy, and care of children with special needs, and managing dental fear and anxiety. She also serves as the co-vice chair of the Oral Health Working Group of the World Federation of Public Health Associations. Please join us in welcoming Dr. Kumar. At this time, I'd like to welcome our keynote speakers and Dr. Weisfuss to please join us up here on stage.
See here.
You sitting over there? Yeah.
Again, if you have any questions here online or in person, please. Do we have a microphone? For the audience?
No, we gotta use one of those. I'm sorry. Arrow's not working.
What is your question? Please.
So I believe I really appreciate all the effort public health, but coming from my perspective as a doctoral student or postdoctoral associate, how can I get involved? What's the best avenue for a researcher who's frankly and sadly a little disconnected from the side, how to get involved in improving oral health?
I would say we all can help, and it's very interesting. One thing I have learned in going into industry is the role that, the media, let's call it, social media, thank you, Rose. But I'm old fashioned, but I have to tell you, the younger generation reaching out on TikTok, Instagram, on all of the social media is, you can make money. You can actually, we see this time and time again, where young people become the influencers, they help people to learn about the things that aren't apparent to them, particularly when they're younger. And they think they're invincible, but we know that young people can also get right? So I think there are things you can do. I don't know what your area of research is, but sometimes even educate kind of work that you're doing and how you enjoy being in the oral health profession. I think is also very good because unfortunately our pipeline for future academicians and people in academia and dentistry is not as strong as we'd like it to be. So I'm so happy to hear your postdoc here and doing work in this field. So sharing that also is very helpful to us. Does anyone else have something?
See, I mean, I'm 100% clinical person, and if you look online. See, they call this public health board, my. Free time, I look back, it's so crazy, at the height of, I had 300, then 300. Over 100 countries with specialists, but emerging too is the clinical. So the clinical people bring out the problems and then turn it over to researchers to help them together. And I think that's the great partnership.
I have a
If
few.
I have more thought for you, will be about translating your research into policy action. Right.
You see them.
They don't want to
Look here.
a lot of positions I have.
You don't need-
The share the screen. So how can we translate the roles?
You stop sharing?
Very
Stop sharing?
I'm the share that. You actually do what we talked about after the fact, see, there's a state presentation. We have an agenda. And
What is that?
and I feel like when.
That's for the camera. Oh. It's not what. What is that? This is.
So what is very advice? That's typically the information side, book to. Actually, groups of the house.
What is this?
But to integrate that, I
Huh?
to get more out. Correct. Very. So I guess I've mentioned some here in the past. So what are your two cents on how to integrate that? Well, in my previous life as an academic, working in a large health center with the opportunity to work with our medical colleagues, our nursing colleagues. It's made a huge difference. And if you think about some of the recommendations that actually New York State was one of the first to come out with the recommendations for obstetricians and gynecologists to recognize the importance of oral health, to recommend that women thinking of becoming pregnant have an exam or and have optimal oral health before becoming pregnant. And that came from, as Steve mentioned, work that we did in the dental school with the medical, so crossing over clinician to clinician, researchers, etc., that drove that work together to change the recommendations that went out in medicine. We do some work with a program called the 100 Million Mouse Program, which Dr. Hugh Silk, who is a primary care physician up at Harvard, has worked very hard to, and recognize, being a physician, that they have very little training in oral health. So he created Smiles for Life, which is a curriculum to educate physicians and other healthcare providers about oral health. Judy Haber, who was here at the nursing school years ago, created the oral health nursing education practice and something else initiative, right? But it was all about oral health education for the nursing community. So I think programs that can help to integrate oral health into the healthcare education system and educate our other healthcare providers about oral health will only help us more. We can't be at every table. We're often not invited to many tables. But to have someone else who can say oral health is essential, why is that not part of this, is going to help us with some of these initiatives for policy.
I think there's been an incredible failure of the American Dental Association dental profession to prove to the world oral health isn't it? No. And I'll give you an example. I feel it's classic. If a child or somebody falls in the playground, you know, I brought up the point that behavioral issues are one of the most important things with kids. Children, folks with this.
You're sharing?
And so if a child falls in the playground,
what's going on with it?
emergency. The emergency room physician has to do what he has to do. He immobilizes the child there and he does whatever treatment and he's a hero. Same situation in the dental world. If a child sustains an injury or something, and they brought to us, and we have to do emergency treatment, it's right, and we do mobilization, stabilization, where water on this fish, you know, like we're criminals. And it got so, you know, we used to use the word restraint, but we now use it's the medical mobilization, stabilization, but how we are working on somebody's face with all the nerves and muscles, and how could we do our work if we are not in a controlled surgical situation? But the minute we mobilize somebody to do that emergency, we're criminals, because this shit is. Where's the dental profession? The practice has to be, again, for example, the people that the data used to be an issue, but it's more and more, and there's so many schools out there. But it's just, it's insane. It's so bad. The pediatric took it out. This 2 years ago, they had the guidelines for medical. That the use of it can cause loss of dignity, children, which became a free ticket for every attorney to sue any dentist that immobilized the patient for a dental procedure. And they took it out, guidelines, but it also caused lots of, you know, things that they did. So, AAD&D, the only guidelines on medical mobilization, which we have to use oftentimes, because what's our alternative? when we have to fix something with somebody, sedation or general anesthesia, right? And now the situation in the country with both use, pediatric mass, there's a 4-year wait for ORs. Most of the years. So when you have a parent or a caregiver that comes to you and you have to, you don't want to use medical mobilization, you have to use sedation and general anesthesia. How do you look somebody in the eyes and say, yes, I need to fix this problem, but there's a 4-year wait for dentists to get operating equipment? It's unconscionable.
Yeah, I think that we're all looking at a similar problem from our own viewpoints, but I think that what needs to happen in this next unit of time is what I've noticed when I've studied this situation, is you
Not
need to
working.
keep widening your lens, the social determinants that are the obstacles to getting to where you want to be. And widening your lens, sometimes in my mind, is connecting the dots. Sometimes it's moving in different countries in all different directions. And it has to do with basic collaboration.
Yeah.
Back to what Maria said, collaboration in medicine, back to what Steve said, general childcare, GYN. Pediatricians, most people don't even know that are capable of putting on fluoride. And they can do that in the pediatrician's office, and then they can even look in the mouth, see what's going on for the patient. Are they doing it? So there's where you have to go to higher levels within areas of, my work on the Commission of Dental Accreditation has to do with a big issue in teaching dental students and graduates to work with interprofessional ability. And I don't know if that's happening in medicine, but interprofessional outreach is like something that needs to be addressed and acknowledged and actually supported in all levels of our own educational processes. And then on the other hand, the collaborative core also needs to supporting these kinds of outreaches in their own way. And another complete way of looking at it is really another thing that Maria said in her presentation. The low oral health literacy, and actually getting the word out in other ways to the communities, have them start understanding that they really need better oral health. They need to show also, that means they need to show up for oral health. They have to, use their own voice, raise that voice. So all of us, to tie in what you said about your research, we all have voice. We all have connectors to others that we can share this concept with. It almost doesn't matter what you do all day, really. You want to take on cause or lands, yeah, you can influence others, each in our own way, in our own demographic.
Thank you all for allowing me to share. I just wanted to share a little from my experience on my doctoral studies, because I worked in integration. And at UBC, they have an professional education curriculum for all health professional students. I'm super proud of that program. It's not perfect. I think it's a great starting point. But I heard something you said where I will just reflect back on that we have oral health policies. That's very good. But is oral health reflected in general health policies? And I think that should be where we want to focus on. Is there that conversation about what non-dentists should be doing about oral health? Methodologies with that. There's a lot of examples. We have a case in oral health that highlights some of the work that or collaborative with non-dentists. And I also know that in Australia, there's a very integrated between oral health, general health systems, and we need a lot to transformize. Something that I could completely resonate with. Thank you for that question. I studied my master's of health at Health School of West, and right now I'm still of health. And of course, no one cares about all. But I say, you guys don't care about us fighting outside of space.
Please speak up. We can't, can you pass her the microphone? Sorry. Online, they can't hear you.
I wanted to say that it's very hard to get what needs to be industry to work with people like me who are outside. So I am a dentist, but I've been working for 12 years in elder care, training with nurses, working with cardiologists, working with policymakers at the New York State level and at the city level. I chair the city policy committee, but I think what happens is we're so busy in our own little silos that you don't have the time. I think there's a desire to do it, and there's conversations that when I meet people in person that there is a lot of interest. But when it comes to actually moving the needle, it's very tricky. So right now, we're working on a policy statement on disabilities. Dr. Perlman introduced me to Barbie, who was based out of NYU. And this is the second policy, this my fifth policy statement. We have one on gun violence, climate change, emergency preparedness, oral health, maternal child health. So I urge you to go look at our website and please join us to, especially if you want to work with students on a policy statement. And I get it, we're all so busy, but there should be a forum on oral health and interdisciplinary health, including people who are not dentists. Thank you. So to answer your question, I think there are a couple of examples, like you just said, where the scientists, the actual answer to show up in non-dental spaces. I'll try to. Is to actually show up, to have that conversation, to make yourself heard in these spaces. And I think we're seeing it in the coming week at the high level meeting that all help is being included. With that, a couple of examples based on what Abby said in our All Health Booklet by the World Federation of Public Health Associations. A project that I'm working on is collaborating with the Tobacco Control Booklet and the Maternal and Child Health. So these are non-dentists that we're trying to have these interprofessional collaborations. And similarly, we're also collaborating with the NCD group. And something that Dr. Ryan said is like when a non-dentist or somebody from a different profession makes a voice, makes a case for oral health, that makes a big difference. I think we achieved that today with Dr. Aurora. So that was a really good collaboration with the NCD Alliance past president, coming in, having the whole presentation for health. So these kinds of events of collaborations in general, whether it is on this level or on research or on policy level, any kind of implementation, I think that's the way to go to make ourselves.
You know, working with physicians, like I told you, this issue of medical compensation, stabilization, gave me a huge issue in dental industry. So we went to our physician colleagues and they did the research and they came up with a policy on medical compensation. It's one policy, whether you're a physician or you're a dentist, medically necessary healthcare is the same in dentistry. And so when we canvassed the emergency room physicians and others, it was only the dental profession that had the problem. Another issue that's coming up that I'm working collaboratively is all of a sudden, I mean, when I
for. And our organization, Glasgow Supporters, was instrumental in having that forum, which ended up on oral health that included the International Association of Dental Research, Federation Dentaire International, and one of our graduates of our student leadership program also presented an award-winning projects on the social determinants of health there. And it got really good feedback. So I just want to share with you, this is an issue, but it's not a hopeless one. Each one of us in our own way and think creatively to see how we can push it forward.
We have a few questions online, if you can hold that for a moment. Dr. Kumar? We're ready for you, Dr. Kumar.
Thank you. We've got a couple, I'll just pick two questions from online. Thank you for a great presentation. That was really enlightening to me as a children's dentist, and I will definitely follow up a few things with the keynote speaker. The first one is from someone asking about how about periodontal inflammation and HIV?
I would just say that people who are HIV positive are at greater risk for periodontal disease. And in fact, we talk about NOMA in Africa and how disabling it can be and disfiguring for many people. And actually, the first time I ever saw such a case was in a patient who was HIV positive in the United States. So they can get very, very severe inflammation, and it's important that it's managed in patients with HIV. I will say, just wanted to make one comment. Deborah mentioned, 1% at a time. And it was great that she invited Dr. Aurora to come to a meeting with her group. And I've done the same with Dr. Nisa Goldberg from here at NYU, a well-known cardiologist. And she came to our AAP meeting. And I'll never forget after she came, she said, "This was great. I love meeting all the dentists, but why aren't you at my meeting?" And that's the question, like, by making those connections, we can get invited to the American Heart Association, American Diabetes Association, and side by side with the medical colleagues go forward at meetings like that to educate much broader community. So, HIV certainly has a connection with periodontal disease, but so many, many NCDs do as well. And I think we need to be at the table. Anybody else?
Dr. Ryan, there was a request online if you would be able to share your slides because they were so informative and had such great references.
Oh, home base, but I think so. I can.
Okay, that answers one of the questions that were online. Dr. Kumar, I think there was another person that had a question.
Yes, the second interesting question is, it's a little bit long, so I'll read that. Once oral health is recognized as a non-communicable disease in an economical climate where countries are struggling, how will this be funded globally?
I would just say, just like we're talking about taking on one professional group at a time, you take on one country. Because various countries prioritize more than others, various areas. We're a global company. And I mentioned that one of our successes with Bright Smiles, Bright Futures in the UK. I just came from FDI meeting. I will say in China, we're working with the China Oral Health Foundation. And in Hong Kong, they had a similar program where they were able to show reductions in caries rates by educating the kids in the school systems. And they have committed millions of dollars to expand that program and provide the kids with the education, with the tools for preventive strategies. Have a similar program that we've had great success in the Philippines and Mexico. So it depends on the country, and some take longer than others. But I think we have to continue to work with the health ministers, the finance ministers, That report actually that I mentioned from the World Economic Forum came about. It was very interesting. They have a global health equity network, which came out with a zero health gaps plan and pledge to educate CEOs all over the world about the importance of health to their employees and to the world's economy. And when I joined that Global Health Equity Network and they gave me the plan and the pledge to read, I said, well, it's lovely, but there's not one word in here about oral health. And I said, my CEO, he will never sign this because that's what we do for our business. Oral health is 50% of our business. And so I had to go and present at that group why oral health should be included, which was some of what we shared here today. And now we have an oral health affinity group within the Global Health Equity Network. It was the first affinity group ever formed within the World Economic Forum. And ironically, the second affinity group was just formed, which is on rare diseases. So it says to me we have a problem when we have the most common disease in the world, and we had to form an affinity group to talk about the importance of oral health and rare diseases, which nobody knows what half of them are, have their own affinity group. So I think, once again, communicating our message is essential. But I had been giving a talk in Mexico with a former governor, Steve Bashir, and many people, some people in this room were on that panel. And after we were done, he said, you all seem very frustrated. And I said, well, Steve, we've been talking about this for so many years, but we haven't gotten where we need to go. And he said, if you don't give the economic rationale, forget about all the data. Maria, you got beautiful data, all this stuff. If you don't give the economic rationale for investing in oral health, it's never going to happen. So that's what that white paper attempts to do. And that's what many people now are trying to do to convince the health ministers, the finance ministers, and the chief dental officers in all of these countries to tell the story that not only is this good for the health of our population, but financially, it makes so much sense.
Thank you so much. I must read a comment from one of the audience, and I think it's an important one. The comment is mention of aging or ageism is important. And while Smiles for Life is great, we need to look at older populations as well. Personally, I had a comment and a question. Working in a small island country like the Cook Islands, where early childhood caries and dental caries is rampant here in the populations, I have struggled for 3.5 years to get Cook Islands on the Bright Smile, Bright Future project. Still, we are not on it, and I thought that we could benefit significantly looking at the high caries prevalence over here. Secondly, I absolutely agree about low oral health literacy, and having the OQ shared globally will be a wonderful thing to do and a wonderful tool for the dentist here, especially in the Pacific, to really find out the levels of oral health literacy and then start developing programs and trying to fill that gap in the oral health literacy area. Thank you so much.
Thank you, Dr. Kumar. Dr. Abiola just wanted to finish a thought. Just give her a moment.
I was listening to Dr. Ryan speak about the economics of oral health, and the question was around where will the government find money? One thing I took away from all these shares was it's very expensive to have dental visits. And you also spoke about that was Dr. Ryan, who spoke about the 6x6 rule. And that really is where the integration should be. If we think about preventing oral diseases as part of general NCDs, it will have a lot of impact. And they're not going to have to be for funds, as it were. It becomes a real component of the health system. We're able to go forward. So we're not looking for specific oral health projects to say, but we're looking for ways to piggyback on what exists already and make use of it efficiently. Thanks.
Okay. I'm happy to answer Dr. Kumar's request. Send me an email and we're happy to help out in any way. Certainly this program, we continue to expand it and we look forward, it's a big part of our 2030 strategy. So we're happy to help out.
Thank you so much.
Fantastic. And there was a question on ageism.
And fastest growing population here in the United States are the older generation. And so certainly their oral care needs are pretty significant. And, you know, some of it also has to do with the programs that you have in various countries. For us here, my mom just passed away, she was 98 years old. And when she got Medicare, she thought, oh, dental is part of it. It's not. And many of us have been working towards getting coverage for seniors in Medicare, and certainly there's been some progress in certain areas to improve on coverage, but unfortunately for many of them, there is not that coverage, and their needs are quite high. And you know, we always think about caries in children, but caries becomes a problem again in the adult population, the older individuals, as their mouth is dry, they're on many medications, etc. And certainly for periodontal disease, risk goes up as you get older as well. And you have many of these other NCDs, which some of them can increase your risk. So I think it's very important. And even though not emphasized in today's discussions, it is an area of interest for us as a company. And certainly for me as a researcher, where I really focused my research on people with diabetes. And certainly many people who are older have diabetes, and they have so many risk factors to consider and so many diseases that they face.
Yeah, I think that's really important in our aging population. It's the fastest growing population, like you said, and I'm seeing a ton of recurrent caries in my private practice that the general dentist can't even keep up with. They come in for their 3-month recall, and each time they come in, I find a new cavity. It's frightening. We have a question in-house here. Thank you so much for being patient.
Thank you. So I work for the U.S. Department of Health, specifically the Affordable Care Act. And as you know, the Affordable Care Act is a law that also includes, you know, the marketplace and dental care, dental insurance within the market. And thankfully, the Affordable Care Act also includes a wonderful group of nonprofit organizations all across the U.S. called Navigators. They go out and do outreach and enrollment for qualified health plans, CHIP and Medicaid. And part of their outreach and education is, you know, telling the consumers, informing consumers, educate them that QHPs, they, you know, not just to enroll in the QHPs, but also the dental. And that's always a shock to the consumers, especially consumers from, you know, certain parts of the globe that are migrating. So just have 2 quick questions. Some posts online claim commercial mouthwash can cause high blood pressure. Like there are a number of dentists online on social media claiming that. One is even claiming that Listerine was once used to clean toilets. So now, how do you combat? How should dental professionals respond to this kind of information? And then secondly, I guess you could say perhaps there's a link between poor dental care and depression. I'm not talking about someone who's just depressed for a couple weeks, right? I'm talking about chronic depression where someone doesn't even want to get up and brush their teeth, or maybe they brush their teeth in the morning, but not at night. So is the relationship between depression and poor oral care something that's being taught in dental school? I assume it is, because as a dental patient, what I'm seeing, well, as a patient in general in healthcare, what I'm seeing is that whenever I go see a new doctor or my regular doctor, they're screening for depression in general, which is great. But what I want to know on the flip side, is that being taught in dental school? Thank you.
there were a couple of things in there, but I will tell you, from Know Your OQ, we learned a lot of things about people not understanding about all diseases, connections between oral health and overall health, including mental health. The preventive strategies people can take in self-care. But one of the other things we put in there is where do you seek care? And many people were not even aware of FQHCs offering dental care, that dental schools usually are the most common place for Medicaid services. Many people didn't even know their dental school might even have a clinic, that their university had a dental school that might have a clinic. So educating people where to take advantage of various programs is also really important. I think the question on mouth rinses, as I mentioned before through social media, thank you, that, we have influencers, and some of those influencers are great, and some of them it's not often science-based. So I just think that, we need to call out when people are influencing and it's not based on science. I'm a scientist by heart. And so the science is incredibly important to me. So if you have something you think is case, show me the evidence and let's have the discussion. So sometimes, that's where Frank says, no, the reporter said, Maria, when did it stop that the doctor was the influencer and the guy who's sitting in his kitchen becomes sometimes the influencer, right? So I also believe that healthcare professionals need to learn how to use social media and be the influencers, rather than somebody who has an opinion, but it may not be backed by the science. So I think we need to have those conversations. And then I guess what was the last question?
Training those, yeah, just the practice of being taught in dentistry.
Yeah, I would say yes, but I'm gonna hand it over to Deborah, because there's a lot of data that connects oral health and mental health and well-being. I will tell you one thing, we did do some work about, you're right, they don't wanna brush their teeth, they don't wanna get up in the morning. And we actually worked with some psychiatrists, and we found that if you could encourage someone to just brush their teeth and get up in the morning, that it was the first step towards recovery. So that oral health also can help on the way towards recovery, and helping in managing people with mental health issues. Fascinating.
That's a beautiful thing to know, actually. I'll just comment on the educational aspect. It's definitely true that it is in the curriculum of dental schools, where students focus on evaluating their patients' dental history and medical history. When they first triage their patients, they're actually taught how to have those interviews and then taught with significant depth, even to the point where almost many schools, if they don't have enough regular patients, the students are required to do these kind of interviews on actors. And the actors, they make sure that the student is qualified to evaluate a complex medical background that could very well introduce, social problems and mental problems and complete well-being. But actors are used quite a bit in the students going through this course, and they have to show competency in it as they move through their education.
Related to your question, I think on depression and oral health, I love your ads with Colgate and Smile, because the importance of Smile. Arizona Dental School had a program where incarcerated women were, when they got released, there wasn't many job opportunities working in like restaurants and things like that, service industry. And so when they had poor oral health, they couldn't get these jobs. So dental school provided a program for incarcerated, recently incarcerated women. I can say, if you don't, the importance of the smile, it's so, I used to get these patients that you needed a SWAT team to get them into the office. And the mother would say, like, gee, can you fix this lip? This one tooth is like crooked. It's like, barely breathing. But the importance of a smile is so And I think it totally, and I don't know if aspects, but totally related to depression, social interactions, and all these other.
Yeah. Yeah, I think there are some publications, Steve, on your opportunities for promotion, what kind of job you may get, all related to oral health, many of these things related to oral health. We do some work. There's a program called Dress for Success. And it talks about how you dress to getting a job. And so we have worked with them on Smiles for Success within Dress for Success, talking to people about their oral health, uh, finding places where they can get care so that when they go out for that job interview, they're well equipped, not just dressed well, but their oral health, their smile, as Steve says, it's great. So as we say, make more smiles. That's our new thing, make more smiles.
I think we have one last question. Please use the microphone so the online can hear you. There you go. Thank you.
Hello. Hi, my name is Andrea. I don't have a dental background, but I am from a public health background. Actually, I have two Dr. Sears, and I was also a board member there. So some of you on this panel. First of all, I just want to thank you all for your insights. It's been a very informative presentation. You all have very extensive experience with stakeholder collaborations and public-private partnerships. So consumer advocacy was touched upon in this conversation, and so were federal and state-sponsored health insurance plans. So as an interested consumer, have there been any opportunities in the space to collaborate with commercial dental insurance companies? And has the expanding oral health research been able to influence coverage for access? Thank you.
I think working with the insurance carriers, that when we were talking about who's missing in the room, more physicians, more nurses, and more insurance carriers, right? Because, you have to have the coverage or the plans that will enable people to actually get much of the care that they need. And that includes government plans or includes the private insurers. And so, I think the insurers are very much interested in how they can reduce their costs. And so that's why you see much of the work looking at oral systemic connections comes from insurance carriers that have both medical and dental. And they can actually look at how increased dental coverage, they may spend a little bit more on that side, but they see the savings on the others. So it becomes, you see many of them start to have programs that provide additional services for high-risk individuals, people with diabetes, people with cardiovascular disease. So I think having the insurance carriers in the room and have them think about how they can increase coverage for high-risk individuals, how they can promote preventive services. And I just think our model in general for reimbursement is for when people are sick is when we get the most rather than for preventive services. And this isn't just in dentistry, but also in medicine. And it's been brought up, why are our costs so high in this country, yet we're not ranked so high compared to other countries in the world for our general health. And many people have said that we need to really look at our models for reimbursement for care for preventive services.
Thank you very much. This has been a very engaging panel. Thank you everyone for participating. Dr. Kieran, would you like to walk us through our survey? And a round of applause for our panelists. Thank you, Dr. Tang. We have a post-event survey. If I could please request all of you in person and online to scan the QR code and please answer the questions. This makes you eligible for CE credits as well. We're offering 3 CE credits. In the form, there is an option to let us know whether you would like CE credits or not. So please, I encourage you all
to scan the QR code and fill it. We can take about 3 minutes. It'll not take you more than 2 minutes to fill this up.
While you guys all do that, I will introduce our closing remarks speaker. I'd like to introduce Dr. Lois Cohen. She's a consultant of the Paul G. Roger Ambassador for Global Health Research. She's a research sociologist. She's retired from the U.S. government National Institute of Dental and Craniofacial Research, where she last served as the Associate Director for the International Health. Having edited and authored 4 volumes on social science and dentistry and published over 150 articles in professional peer-reviewed journals, she is purported to be the architect of behavioral and social science in oral health care field. She co-directed 2 major multinational collaborative studies on oral health systems with the WHO and who have led the WHO Collaborative Center for over 20 years. Currently, she serves as a consultant to the NIDCR, the WHO, as well as other various organizations and universities focused on global health through oral health. Awards and/or honorary lectures in her name are given annually at Harvard University, School of Dental Medicine, the International Association for Dental Research, Purdue University, and at St. Joseph University. Please welcome Dr. Lois Cohen.
Thank you. I'm particularly proud to be here. I'm one of those aged populations that you alluded to before. But I come to you very excited about the Alliance for Oral Health Across Borders. That really was the spark that convened this side event. It is the very first one in our field that is focused on raising the public's voice, raising civil society's voice. And I must recall that the whole notion of the prevention and control of non-communicable diseases was raised at the UN in 2011. And we were part of this movement at NYU, where we had the very first side event to introduce putting teeth back into the body. That was on September 19th, 2011, and under the kind auspices of the then president of Tanzania, Kikwete. Here we are, September 21st, 2025. And we've had several iterations with the UN General Assembly over this time to make sure that oral health was included in the NCD proclamation and it later on the NCDs as well as universal health care coverage. So oral health has been included. It was exciting for me to read just yesterday the new iteration of the what they call the zero draft that will go to the General Assembly this Thursday. And I looked for oral health. In the previous documents, it was 1 or 2 words, oral health, put into a line. I remember the first one was in, I think, section 19. They inserted oral health. Looking at this new draft, it's in at least 3 times and implication several more times. So in fact, there's a whole paragraph on it. So I commend you to read it, and let's hope on Thursday it is approved. That's really terrific, and it's very encouraging. And I want to repeat the notion that civil society has a lot to do with the pressure put on ministers of health from each of the respective member states to act on this. On August 25th, just last month, the World Health Organization Regional Committee for Africa approved a framework, a whole framework for oral health across their 29 member states. It was extremely exciting for that to occur as well. So great progress has been made. And I just want to make an aside of what some of you may not know what the ambassador title is next to my name. When I retired from the US government as a full-time employee, I'm still working part-time, but I retired in 2006. And the Gates Foundation gave the poll to the Research America, which is a major advocacy group for promoting policymakers to invest in biomedical and behavioral research. They gave them a bolus of money and created the Paul Rogers Society for Global Health Research. And the reason was they had to convince the US policymakers to invest in global health because they were just investing in a national research portfolio with a little bit, less than 1% of any went outside of the country. So the lessons we ambassadors were dubbed to take, asked to take, was to explain why do we go global? Why invest globally? Well, this is the reason. We find out what's going on in other societies and we learn from it. It's in our own national self-interest. No matter where you sit in any country, you need to go global. You need to learn in a reciprocal way. It's not just highly industrialized countries looking at other highly industrialized countries, but there are lots of cost-effective ways to intervene, to advance health research or health of the population that are less highly technical, high cost. So we can learn from low and middle income countries and highly industrialized countries and vice versa. There's much to learn by looking outside of our proverbial box. And that's what my role has been since 2006, specifically to carry that message. And I am very grateful to be honored to be part of the Alliance for Oral Health under Dr. Weisfuss's leadership. She has really transformed it and provided a platform for all of us for reciprocal learning. So thank you very much. And I wish all of us much good luck as we go forward and use some neutral platform, whether it's through common risk factors with the non-communicable diseases and with the infectious diseases. Mind you, I always quibble why we're in with NCDs because all diseases, even cancer, has infectious elements, and Maria and others have spoken about the infectious side of oral diseases. But we have common risk factors, whether you use the 6x6 paradigm, we can use those risk factors as ways to collaborate. So we collaborate with tobacco control, with alcohol, with sugar, um, uh, with advocacy groups that want to modify the amount of sugar in our diets, with accident prevention, etc. We can use those common risk factors as a platform to collaborate. So that's another opportunity. Let me finish by saying also just giving a plug for, well, even before I do that, let me just say I have to acknowledge the people who have asked questions related to some of the constraints that we face today. Some of them have to do with the fragility of our international health organizations, including the UN and the World Health Organization, WHO suffered 20% cut in budget. Needless to say, we have the same situation in our own country here. But all international organizations are very fragile at the moment. We also have the threat, we've alluded to it, of shrinking trust in our agencies and or organizations. We have to recognize that. And finally, that we're working in silos still, and that we have to work towards intersectorial collaboration. Those are constraints, but they can also be opportunities. And some of the opportunities have to do, in my mind as a sociologist, with socially responsible public-private partnerships. We've already heard about some of them today. I think we have to think of new ways of funding. When funding is cut off from one source, we have to think of pooling resources. And so those ideas where we have small national pockets, we could have pool regionally. And we can pool funding across organizations as well. So we collaborate with other non-governmental organizations. So those are just a few of the ideas, but they are opportunities that foster intersectorial collaboration. So while you gave the example, Maria, of Dress for Success, integrating our ideas into other organizations and pooling resources so that your money is leveraged is another way to proceed. And I remember going through this at NIH, when we had our first budget cut, just when I was appointed director of extramural research, we had our first major downturn in budget. We introduced the idea of collaborative funding, and we thought, oh, that's never been done before. People say the gold standard was an NIH grant. We don't ever contaminate it with other sources of funding. Well, we changed that, and we had highlighted case studies of where we thought we didn't do it, but we found where we did. Collaborate with other government agencies, collaborate with the not-for-profit world, say with Juvenile Diabetes, Osteoporosis Foundation, Cystic Fibrosis Foundation, and thirdly, collaborating with the private sector. All commercial determinants are not bad, and we've just heard from some very good ones. So think out of the box. That's my closing remarks, and thank you very much. It's been a wonderful, stimulating meeting.
Thank you all. Thank you so much, Dr. Govind. That was wonderful. I don't know, Dr. Tang, if you want to say anything in the end. Okay, I'll just put this back up for those online and in person who would like to fill out the post-event survey. Go
I
ahead.
just want to thank everyone for coming and enjoying the conversation, spreading it, and I deeply also want to thank our keynote speakers for their standing contributions. It's really a great experience to be here.
Thank you so much. Thank you all. Please just join us outside. There might be some more bagels, but we'd love to meet all of you. Thank you for being here this Sunday. Thank you.
Yes, we have
We can have a group all together here, how are you? Maybe you can ask, yeah. Last time we did it last year.
I would like to request everyone in person to meet outside for a group photograph.
Everyone goes, we've had a. We had. Yeah, yeah.
Yeah.
You still working?
Okay. Thank you for graduating.
Okay.
Want to say something?
Let me see it. Tony, let's go.
Say something about this. So we have a time.